Good afternoon, everyone. My name is Iman Williams, and I'm the Health Education Program Manager for the Louisiana Department of Health's Bureau of Community Partnerships and Health Equity. Our Bureau is devoted to increasing the citizens of Louisiana's knowledge about what affects our health, especially underserved and under-resourced communities. This devotion is rooted in awareness through webinars and collaborating to ensure all communities are healthier. I want to let everyone know that we'll be offering CEUs to nurses and licensed clinical social workers. Those requesting CEUs will need to complete an evaluation. Please scan the QR code on the slide to access the evaluation. Once you complete the evaluation, your certificate will auto-populate. Next slide, please. This is the agenda for today's meeting. First, as you can see on the slide, we're going to have the welcome, and then we're going to go into an overview of health equity. We're going to introduce the moderator and panelists. We're going to have a moderated panel discussion. Then it's going to be our Q&A session, and then I'll wrap up. At this time, I would like to introduce Ms. Avis Richard, who will be providing us with some welcoming words. Ms. Richard is the director of LDH's Bureau of Chronic Disease Prevention and Healthcare Access. Ms. Avis?
Avis, you're on mute. It's not working.
Can you all hear me now?
Yes, we can. Thank you.
Awesome. Thank you, Iman, for that welcome. And thank you all for joining us today. We put together a stellar group of individuals who will discuss the importance of addressing differences in where we live, work, play, thrive, and worship. And you're going to learn how those differences are very important when we address social determinants, and to help ensure that everyone has an opportunity to achieve their greatest level of health. Welcome to this webinar, everyone. Webinar is titled Identifying Social Determinants of Health in the Community. By hosting this event, we hope to increase awareness about health-related social needs, cultivate partnerships and resource sharing to improve the lives of community members across Louisiana. During the COVID-19 pandemic, health equity became a national and state priority, a local priority, across our communities were impossible to ignore. Based on factors like community members' race, social and environmental conditions, as well as access to health care and basic life needs, we all witnessed how COVID-19 impacted us differently. Today, we hope to shine a light on how several public health practitioners are combating health disparities by addressing health-related social needs and improving access to healthcare services and resources in the communities they serve where we live. I'll turn it back to you, Iman.
Thank you, Ms. Richard. You will hear 5 facts throughout the webinar. First, next slide, please. Health equity means increasing opportunities for everyone to live the healthiest life possible, no matter who we are, where we live, or how much money we make. Some people need additional opportunities and resources in order to achieve health equity. Social determinants of health are conditions and environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. Access to primary care services, such as early detection and treatment of disease, chronic disease management, and prevention, and preventative health care is associated with positive health outcomes. Disparities in access to primary care exist, and many people face barriers such as language-related, transportation, shortage of providers, and lack of health care insurance. That these decrease access to services and increase risk of poor health outcomes. I want to stress the importance of getting information from credible sources like the CDC and LDH. During the webinar, we are going to be sharing links in the chat box and also some information with you after the event. And now I would like to introduce our moderator. Our moderator and our panelists are going to educate us about health-related social needs in the community and share resources to improve everyone's access to healthcare services and information. The moderator will guide our conversation, and participants will have the opportunity to pose questions in the chat box, which will be answered by our panelists. Also, someone from our Office of Behavioral Health will be in the chat box responding to questions about their preventative health and support services. And now I would like to introduce our moderator, Dr. Tanya Jagno. Dr. Jagno is an associate professor of clinical medicine at Louisiana State University's Health Sciences Center and an adjunct professor of industrial engineering at Louisiana State University. She is a board certified in pulmonary medicine and critical care medicine, as well as clinical informatics. She serves as the Chief Medical Informatics Officer for Our Lady of the Lakes Regional Medical Center and is a consultant for the Franciscan Missionaries of Our Lady Health System for healthcare analytics and artificial intelligence. She has directed social determinants of health screening, documentation, and referral management systems across the Franciscan system. She has optimized social determinants of health platforms with electronic health record system EPIC for clinical documentation, initiatives, and third-party resource search engines that connect community-based organizations to patients with social determinants of health needs. She continues to work using technology to address social disparities and inequities. Dr. Jagno, thank you for moderating today's discussion. I will turn it over to you.
Thank you so much. And I do believe we have a few slides. I'm looking forward to the conversation. Before getting into the slides, we have a very talented panel here with us. And Iman and Avis, my question to you is, do you have access to their profiles or their bio? Because my link is not working. And that's, technology is supposed to be my area of specialty.
We will let them introduce themselves.
Okay, that's probably the best way to do it. So I'm going to start off with the panel. I'm going to call you by name and ask that you can give us your background and a little bit about what you're going to be contributing, and then we'll get into some specific questions for the team. So starting out with Ms. Deborah Evan, if you could tell us your role and background and discussion for today.
Hey, good afternoon, everybody. My name is Deborah Even. As you can see from the slide, I'm the Chief Public Health Nurse. I sit in the Center for Community and Preventative Health in the Office of Public Health, and I am in the Bureau of Regional Clinical Operations. I am an APRN and have a public health background, and I'm also Latina. So I worked for many years in the New Orleans community in federally qualified health centers and in public health, and this role kind of combines the two. We are over, myself and my colleagues and our central office folks are over the 60 plus health units around the state that are run under the Office of Public Health. And so I'm going to be sharing some information regarding what services we have and how we have tried to address health inequities as far as our health unit services go. Thank you.
Thank you, Deborah. Dr. Donna Williams.
Hi, I am a professor at LSU Health Sciences Center, New Orleans in public health, also the Associate Dean at the School of Public Health. But in this regard, I am the director of Louisiana Cancer Prevention and Control, which is our programs in our state that are centered around decreasing the burden of cancer in Louisiana, with a particular emphasis on underserved and under and uninsured.
Great to have you. Mr. David Alvarez. David, you may need to unmute. Sorry.
Oh, sorry.
That's okay.
Afternoon, everybody. Y'all can compare how I looked before and after I go get my haircut and shave with my two pictures. But yes, I'm the director of La Luz de la Comunidad. My parents are from Cuba. I am about 20 years here working in behavioral health, and prevention in particular is my expertise. I wear several hats at La Luz. I also do all of our data and evaluation services internally and externally as well. And I'm here to talk about what we're doing and what we're seeing and to inform this discussion. Welcome.
Excellent. Thank you, David. And Dr. Jillian Addison.
Hey everyone, I'm Dr. Jillian Addison. I am the director for Louisiana Spirit's post-COVID crisis counseling program, and it's a brand new program for OBH in that we have had many COVID, not COVID, this is where I will say, crisis counseling programs, but they were always related directly to a federally declared disaster, and money came through FEMA and SAMHSA. This, however, is a really unique opportunity for us to branch into meeting a much more equitable group of people and communities and provide services in a different way, because it's not shelter oriented or just the people impacted from that disaster, by it being a post-COVID crisis counseling program. Funding's through CDC and Office of Public Health, and we are building in every equitable possibility that we can think of, because our work is primarily outreach first, and then to individuals. So we're very happy to be here. We are looking forward to working with all the other panelists in the future to provide care for everybody. Like everybody. Thank you
Excellent.
for having me here. Yeah.
Thank you. All right. So I do have a couple of slides. If you guys could bring those up for me. This lay a little bit of the foundation, but we're going to get a lot of content from the panelists and their expertise. So Iman or Avis, I'm not sure who's driving slides there, unless I'm supposed to be sharing them, which is not what I have teed up. Do you guys have my slides? I can in like 30 seconds.
Dr. Gino, could you please tee it up? I do
Okay.
not have.
So we're all going to be patient with the LSU server that's been slow today to open my LSU email. And if it doesn't in like the next 10 seconds, we're going to forego that, and I'm going to just give you content from memory. There we go. Miracles happen. You know, it's going to be a good discussion when you have at least 5 to 10 IT issues right off the bat. So appreciate everyone's patience.
While you're doing that, I'll just throw this in there that about 25 people at LDH also could not even log in the first place. So
Yeah.
most of us, I can't access any files on my computer. I can only access Safari and Outlook. So, you know, we're just going to go with the flow today.
Blessed are the flexible, for they shall not be bent out of shape. Yeah, our LSU servers, for some reason, they were restarted as we were starting this program, and I knew that's where my slides were. And so thank you everyone for being patient. I do hope that the folks who couldn't log in can ultimately do so. And I will set up slides for viewing, and I'm gonna rely on you guys to tell me that you can see it. Hopefully now. Thumbs up. Health
Yes.
equity, excellent. Okay. So you saw one of my interests was artificial intelligence. All the images you'll see are generated from artificial intelligence. And it's just interesting when you put in the prompt and ask for terms like equity and balance, what pictures you get out of it. Because that language model is built of language that we've used somewhere, and it's learned from it. And so in this next picture, we have what is equity, and most of the prompt was centered around figuring out what is equity from how a language model interprets that. And I like the fact that we have such a diverse group of individuals with varying abilities that came out of a language model doesn't mean that they are equitable, but it does suggest that there is hope. So ensuring everyone, regardless of how they come to the table, has the opportunity to maintain their highest level of health is our definition. And what we'll focus on today, there'll be some content about COVID and how it's impacted the ability for folks to take care of themselves. And you just know that, well, COVID was a tremendous disruptor, very much uncovered problems. Like we had problems in COVID, like here's the spotlight. With that, we should be smarter. And so I'm interested, and I know I'm going to learn a lot about strategies to improve healthcare access, and many of the things that we've learned were broken. And then there'll be some special focus on language access to services and other accommodations from those who are limited by communication for whatever reason. I did want to bring some of our data, and I say ours, big part of electronic health record is what I do, and we have access to a database that can pull generally from Louisiana and Mississippi. And this is looking at zip codes where you have a certain percentage above or below the poverty line. And as you can see, as we go to zip codes that have more poverty represented, we also have more representation of disease. Heart failure is in green, I'm sorry, purple, hypertension is in green, and diabetes is in this magenta color, and a very clear relationship between socioeconomic status and disease burden. If we look at children, these are less than 18, same scenario is pictured here. When you go from increasing levels of poverty, we see more conditions. The denominator is different here. With adults, we were at 800,000. We're at 80,000 for children, but nonetheless, the pattern is preserved. And these are common things we see in kids, and these will ultimately become part of what builds those conditions that we just saw in adults if they're not addressed. If you look to the CDC as one of our references for information, there's a vulnerability index, something that, you know, if there was a natural disaster, what's your capacity to recover? And in the dark blues and greens, there's a high vulnerability. If we were to get the flood or the hurricane scenario, these are the areas that are slowest to recover and hardest hit. If you break those areas down into specific social determinants, socioeconomic status, household characteristics, racial and ethnic minority status, or housing type, you see that overlay of where the hotspots are. And so there's no doubt that when you have inequity and you have this vulnerability, that you have conditions that are preventable, but that impact our individuals who are concurrently impacted with those problems. And they are treatable and preventable. And it is one of the goals and objectives is to see how can we move closer to eliminating this color burden and getting into the lower vulnerability indices and reducing those disease burdens. Language in particular is critical because it's the way we, tell our providers or our community what's wrong, our voice. And there are a number of areas that I think that we could certainly do a lot better. This is a screenshot of our language line, generic screenshot in the hospital. And this allows us to communicate, but we know that this is only a small piece of it. And if I were to dive into who needs language access, we have the issue of not speaking the language. We have the components of individuals who are preferring to communicate in their language and cultural overtones. And when we don't communicate as a provider back to them, we don't message correctly. There are folks who have difficulty with hearing. And then there are those, for whatever medical condition, have a disability that prevents them from being able to communicate. And this one struck me as I was doing research in older adults. This is something we see often, but reminds me of my grandparents who reverted to French whenever they had some medical conditions, and one of them had a stroke and would essentially stop speaking in English. And so I know that we have a very colorful state, and this would not be surprising if there are changes over time in the ability to communicate in proficiency of language. So with that being said, I'm going to stop sharing, and we're going to have a great conversation with our panelists. Thank you for the introductions. And if it's okay, I'm going to call you guys by name and direct the questions to you, but we'll also allow a little bit of chat time in addition to some conversation from the other panelists with their really great points to be made. So Deborah, if I can start with you, I'd like to know what services does LDH's parish health units provide, and how did the COVID-19 pandemic impact patients' ability to manage their health?
Yeah, so the parish health units, we are almost in every parish. We don't run every single health unit that's out there. Some of those are done by those actual parishes nowadays, but we do have the vast majority. We offer reproductive health, which is Title X funding from the federal government, and that is, it encompasses not just family planning, but also STD testing and treatment. Our TB program also sees patients around the state for testing for TB and the treatment. And we know that the treatment for TB can be lengthy. And so that's an important public health issue to tackle and to ensure that we stay on top of. So they do contract with different physicians around the state. And I will say that, well, I'll go through that and then I'll say a little bit more about, what we've moved to since COVID-19. We do childhood immunizations typically, and these are services, and COVID also has impacted, and just the voice of the communities have impacted our services for immunizations, improved them. So that's the Vaccines for Children program primarily. That's what it was when COVID started. Children's Special Health Services also run under our Bureau of Family Health. Those first two, so reproductive health and the Children's Special Health Services, are under our Bureau of Family Health. The TB and immunizations are our Bureau of Infectious Disease. So we have a pretty broad reach into other or from other bureaus within OPH. And then our last one would be our WIC program. And while WIC does have very a broad reach throughout the state, they have contract partners that are not necessarily in a healthcare setting, but we do have those wrapped into ours as well. And so those are the primary services. Obviously, being the Louisiana Department of Health, we have many other folks that sit out there, things to do with, engineering and water and other things, but those are our direct services. So these services, the vast majority are folks just kind of knowing that TB is not, the biggest money maker, so to speak. So there's not a whole lot of private physicians that are taking that on. So our program really does well. And so if you're uninsured, we are definitely treating you. We are public health, and that is first and foremost, it's our mission to take care of our community. And so a lot of these services, if you are uninsured, you can access them through our services. I will say up until, the ending, I call it ending, or the evolvement of COVID to being more manageable, our folks that were insured had a little bit more difficulty accessing some things such as immunizations. And over this past summer, we really tried to implement programs that will allow our community members, really got used to us being the go-to in those parishes for COVID vaccines. And so we really tried to meet the need of the community and the relationships that we established, for example, for immunizations with those. And so we have, with our immunization program, started offering a lot more vaccines to folks that are commercially insured, which is what our communities wanted and needed. We really tried to respect their voice. The other thing I was going to mention is that telehealth became a big push during COVID. And that's primarily what we did for these services. And we had to scale back services tremendously because we are public health. And at the beginning of the pandemic, we were in a lot of nursing homes, and we all know that that's where a lot of the nursing homes, that's where a lot of COVID, came to light in the nursing homes. So we did a lot of work with the nursing homes, for the nursing homes, trying to help them in every single realm. And it was close to 6 to 8 months until we started to put our services back into place as other partners stepped in that were a little bit more, had a little bit more resource, because our ranks were overtaxed, frankly.
As a pulmonologist, I'm a big fan of all the services that you guys provide, and particularly TB, recognizing the consequences. Aman has put the link for the units in the chat. For those of you who are not don't have that open, just be aware that that's there for you to discover. Thank you, Deborah, and we'll be back to you shortly. Next question is for Dr. Williams. How did the COVID-19 pandemic and the resulting shutdown impact cancer screening access? And follow-up, were there disparities in cancer screening rates among certain populations? If so, which populations, and was it specific to certain areas? So a three-part question: impact of COVID and screening, and what were the areas and the different groups and populations most impacted?
Sure. Yeah, we saw a definite decrease in screening, and we're doing deep dives into those data now, because some of our data lags a little bit, but we definitely saw decreases in breast screening and colorectal screening in particular, two cancers that colorectal we can prevent, and through screening, and breast we can detect it early and cure it. So it was unfortunate that we saw those reductions. And that was, there were a number of reasons. A lot of clinics were limiting who could come in and how many people could come in, which made it difficult to access services. People were making decisions to limit where they went and what they did. And so, of course, they're going to put preventive services more in the background, and only, when they're making those limitations, only come into a clinic when they have an issue that needs to be addressed. And with colorectal screening, it became even more of a problem because they, of course, we know that the COVID could be found in fecal matter. And so when you're doing colonoscopy, there's an issue with that. So they were, sort of upping their game on sterilization, and double and triple sterilization of the equipment before seeing another person. So that increased the time between patients and reduced how many patients they could see. And so we already had a shortage of colonoscopy services in Louisiana, and that way it made it even worse. And that also impacted who had access. So of course, most of our health services are in the metropolitan area. So we had huge rural disparities where people had to go farther and farther for services and wait longer and longer. And we already had a shortage of GI docs who would take Medicaid. And so then we saw that access for Medicaid patients reduced as there were fewer slots for colonoscopy. And, same thing for the uninsured. It was harder and harder to get in for these kind of preventive services. So we're beginning to see our screening levels return to pre-COVID levels, which we're excited about. But we're also starting to see, as we expected, more late-stage disease from people who postponed their screening for 3 or 4 years past when they should have. So hopefully, the message is get that screening now, because these are two cancers that are huge in our state. We have large numbers, but we can certainly keep people from having a decrease in quality of life or even dying from these two cancers.
Totally agree. I think the aftermath we will continue to see for 3 to 5 years and catch up. So appreciate your points there. David, if we can pivot to you. According to the NIH, the Hispanic Latinx communities had a significantly higher rate of unmet mental health needs during the pandemic, more so than other racial and ethnic groups from August 2020 to February 2021. What barriers has this community in Louisiana experienced in accessing behavioral health services in particular? And you mentioned your group, La Voz de la Comunidad.
Yes.
Pardon my French influence there. What are they doing to improve behavioral health services among the Louisiana Hispanic Latinx communities?
Yes. Well, I guess where I like to start is that just the nature of Latino communities is that you take these issues that we see in other communities and throughout the state, and they're just exacerbated when you look at our population of Latinos here in Louisiana. So I like to start off with giving an example from data. We during the and this is all pandemic related, topic related. During the pandemic, we surveyed. We surveyed over 300 solely Spanish speakers in the greater New Orleans area, and we asked them a bunch of questions about pandemic and accessing services. And just as a not an aside, but we are always focused on accessing services. That's always our prioritized need. In our community groups that we work with, our coalition and everything, it's always our prioritized need, and it's always so it's a big issue. So whatever service is out there, it's hard enough to get people to access services, as we all know as professionals. It's just exacerbated when we're talking about Latino communities. And we had the survey, and one thing stuck out to me, and I'd like to share with you. It's when the government took out a check to United States residents, not necessarily all citizens or documented, but just everybody that just to help people here. The census did a survey and found that about 86% of people got a check. When we did our survey, how many you think, what the percentage do you think of our people? It was 36%. So 37%. So, and this is just another example of how whenever, our government couldn't give 100%, even though it wanted to, it couldn't get 100% access to that one service. But here our population is at 37% access to something that 100% should have gotten it too. And of course, the survey showed that across the board, if a typical American family, if let's say 30% of a typical families lost jobs, well, in our 300 surveyed, it was well over 60. So, and that just goes down across the list. So every conceivable negative impact of the pandemic that we can discuss, the majority, we could illustrate that the Latino communities suffered disproportionately in compared to other groups. And so I think that's something to discuss. And as regarded as an agency, what we did a lot of things. The governor's office contacted us. We helped them get masks to communities. I like to focus on Latino families that I know aren't going to be touched by the typical networks and systems of communication that we use when Department of Health Hospitals or all the nonprofits that are associated. I always say that, that abuelita that just recently, like when the waters were the Mississippi levels were decreasing, and they were scared of the salinity and the salt coming. We were gearing up here to go into the apartment complex and go to the little abuelitas that we knew had no idea what was going on and knew that they were going to be drinking the water out of their faucets. And we knew that. So we were gearing up just to go to the places that we knew that just because of language and because of just modes of communication, and because of immobility, that they weren't leaving, that they weren't going to be traveling to get to the centers that had all the water. We were coordinating to get to those folks to bring them water just in case. Well, same thing for the pandemic. We were bringing masks and whatnot. I think that a big impact for us too, and this is also across the board, but just disproportionately bad for us, is just mental health services in general. Our folks today have months and months and months of wait time to get to Spanish-speaking clinicians to talk about whatever mental health issues they're having. We're talking 8 months, 6 to 8 months. And I know that this is nothing new. American English-speaking Americans might have a wait as well, but it's just it's really our folks, if they want to seek mental health services, it's practically impossible to get a Spanish speaker to help them here. So I think that's another big thing that the pandemic really impacted as well.
Thank you, David. And I agree. Part of the language barrier is actually just the proactive messaging. Like you said, it's a great point to make. Is if we watch the news and you get the messaging, but you don't speak the language, then there's a whole risk of what's coming and you're not prepared. Next question, I'm going to pivot to Dr. Addison. That's okay. We are aware that the Office of Behavioral Health reestablished the Louisiana Spirit Program post-COVID. You mentioned a new program. Can you explain what services are offered to the community members? Why was it important for Office of Behavioral Health to reestablish the program?
Sure. So the mission of this iteration of the Louisiana Spirit is to assist individuals and communities in recovering from the effects of COVID-19 through the providing free community-based outreach and psychoeducational services. So what OBH was finding was that we had a COVID CCP and we had multiple disasters during that time. And when those wound down, the communities we were serving were really upset because much of it is free community-based outreach. And so it was very noticeable that we were gone all of a sudden. So what we primarily offer is short-term interventions that our crisis counselors provide. We call them crisis counselors, stress managers, because we're technically not in a crisis right now. But they do group counseling, they do public education about mental health challenges, and coping strategies for how to get through life as we know it now. Stress management services that assist children, families, elders, first responders, small businesses, rural populations, and any other special population, which in my brain, that's the wording we have, but my brain goes, everybody who falls through the cracks. That's what I call those people. And that's who we're talking about right now. The folks who, whether they purposefully or not, are just unable to get services that they need. So some of the specific things we can do is psychoeducational presentations on building resiliency, compassion fatigue, caregiver fatigue and burnout. That could be a teacher or a community member. Grief and loss, as you all know, a lot of people had multiple losses during the COVID period that they were absolutely not able to experience in any way they normally would have because of not being able to have public gatherings. So many people never actually dealt with the grief of grandma dying. And I say many people, I mean, we're grown-ups here, but you know, kids in schools, they might be dealing with the fact that their mom is super, super depressed because her mother died from COVID and lived 2 towns over, but nobody could go to a funeral and not celebrate it, honor it. And then we have holidays coming up, of course. So that always exacerbates people's emotions. So then we also have presentations on work-life balance. Some of that's geared more towards the employees of places who help other people. And then small businesses and of course, your first responders, but also complex trauma and vicarious trauma. And that's where you have a multiplicity of traumas that happen over and over, and or we see things over and over, like everybody's seeing the news about a war right now, but then we had a crash in a super fog one day a couple months ago, and when that was on the news for a minute, I thought it was a war zone, and I didn't know which one I was watching, and I'm pretty grounded. So a lot of people who have it on 24/7 are having a lot of issues with the complex trauma and also the trauma that these things are bringing up after COVID. We all went back to normal. There is no normal. There never really was. Normal is just whatever we're comfortable with in our own group of people. So it seems that there's a lot. I don't know if you guys work in the medical field. Seems like most of us are, sort of. COVID seems to be everywhere right now. So I know I have 4 members of my family currently, not my family in my house, but my extended family who have COVID, who didn't think they would get it now. Like, why now, right? So all of a sudden they're having those same issues of, well, wait, is this going to be as bad as back in 2020? And what if, and what if, and what if? So we're doing a lot of work to develop programs that can be adapted to every group possible on managing feelings around this. And right now, currently, we are actually in the outreach process mainly. The way our services work is more of a outreach, and then we go places and do these things. So for instance, some of it's as simple as being at a flu clinic or being at an event at a senior center, and being there with some of our resources. We also have a machine called the M-Wave that is a computerized, almost like a biofeedback. It measures what's going on in your body, and the participant can actually see it on a screen. And I don't know if any of you guys know, but if you've ever seen any biofeedback, or heck, if you have seen your blood pressure, you know what happens when you see a high one or a low one or a normal one. So then we have our stress managers who are able to help folks who see something high, and they can follow up with talking about how to change that. So we're trying to get that out into the public more often. And what we are doing is really just adjusting the things that had been used prior in shelters and with survivors from Hurricane Ida and all our hurricanes, to the world that we live in now, because basically everybody is going through a lot, and we're not going to ignore it anymore. So
Excellent.
yeah, so I'm looking forward to this community that we are building right here, right now, to be able to help in that specific equity piece, because that is where not having a captive audience in a shelter is a challenge for us on this go round. But I fully believe we can make it work and get to the people who are falling through the cracks.
Excellent. Thank you. Much
Thanks.
needed. And we went from acute crisis to chronic crisis condition, it seems, where we are in a sine wave. COVID, flu. I agree. It's not gone. It's a part of life, and there's still a misunderstanding about how much we can be impacted by things we think are benign, such as new COVID, flu, etc. I'm gonna go back up to our lineup. Dr. Williams, if you could talk a little bit about New Orleans conducted a study of racial differences among cancer patients hospitalized for COVID. And I'd like for you to sort of touch on that study, and how could we use this information to address disparities. I'll let you tag on to that what resources are available to patients who need language access services and other accommodations when you're considering cancer screening.
Sure.
Mhm.
Yeah. So what our Louisiana Tumor Registry did was they looked at people who were diagnosed with cancer in 2015 and 2019. That was about 6,300 cancer patients. And they looked to see how many of those were hospitalized for COVID infections in 2020. And that ended up being about 1,300 of those patients ended up being hospitalized in 2020 for COVID. And when they looked at the distributions of those white to black, they found that 17, while the black cancer patients were about a third of the sample, which is congruent with our state population, and about 2/3 were white. But they found that while 17% of the white patients were hospitalized, that 27% of the black patients were hospitalized. So there was a large disparity in the hospitalization rates for cancer patients between black and white patients. And when they broke that down a little further and looked a little further, they looked at comorbidities. So we know that there are certain comorbidities that are associated with poorer outcomes from COVID. And they found that about a third of the white patients had no comorbidities, and about a third had 3 or more comorbidities. In the Black population, non-Hispanic Black population, they found that about 21% had no comorbidities, and a whopping 44% had 3 or more comorbidities. So the the take home for me on this is a couple of things that, as we're looking at things like COVID happening, and, we may be seeing more and more of these kinds of outbreaks, we need to be aware that there are certain populations that may have disparate impacts from those. So if we know that up front, we need to be more concerned about a particular population and they may have a worse outcome. Then we can get that information to our healthcare providers, our social services providers, so they can work with those patients, and also out to the public so they can be aware. Don't if you're in these categories, if you're somebody with cancer and you have a number of comorbidities, don't wait to contact your healthcare provider, to go to the emergency room, whatever it is that you need to do, but that you're at a higher risk, and that we need to all be aware of that and act accordingly for people that are at higher risk.
Absolutely.
um,
I echo that. As
yeah.
a physician, we didn't know these numbers, but we saw it.
Yeah.
And so there was a picture of comorbids that
Yeah.
when you saw COVID, and you described exactly my critical care experience
Yeah.
in
Yeah.
2020.
And also, to be more in tune with the whatever kind of provider you are, more in tune with the patient's history and what may put them more at risk. In terms of the language access, many of our partners at Louisiana Cancer Prevention have speakers of language where there are larger populations in their service area. For example, we have a partner in New Orleans East where there's a large Vietnamese population, and they have Vietnamese speakers out there. And then same thing with Spanish speakers, where there are large Hispanic populations. Here in the central office, we have Spanish speakers, which is probably our biggest language need in the state. And so if someone does not have someone Spanish speaking in their area, they're more than welcome to give us a call, and we'll or shoot us an email, and we'll get them on the phone or whatever we need to do with one of our Spanish speakers. All of the healthcare providers are required to have language access, and it may be phone, but and that may not always be the best thing, but it is available. We also have navigators here in the central office, so if someone has a language issue, they may need to find an English speaker to help them work with our navigators to find them the access that they need, but we'll certainly work with them to get the interpretation that they need.
Excellent. We're going to stick with that theme of communication. And Deborah, if you're up, we're aware that, and you mentioned LEH offered telehealth during the pandemic. Was it available for all of services that could feasibly be delivered through telehealth? And after COVID, tell us about the state in what are you doing in the post-COVID access period. In addition, resources available to assist with older adults. Again, interacting with technology is a barrier, as we know. And so you can just comment on that as well, with our strategy sometimes being virtual in delivery of healthcare now.
Yeah, that's true. And so I will say that the biggest push, or the largest volume of people that we saw via telehealth, was our reproductive health, and that's our family planning and STI. And there are definitely some limitations. If you have someone, that wants long-term family planning, that cannot be done via telehealth. So we really had to instruct our staff and come up with, a way for them to triage when they received phone calls, like who is eligible, who are the best people. So it took a lot of work to do that statewide. And I'm sure we were not the only ones, but we're going to talk about family planning, definitely. Our nurse practitioners got very good at doing what they could on telehealth. and pulling in, because we do use phone access for interpretation, pulling those interpreters in on the phone on their end. So because of the way that we have our interpretation line set up, we call them, but we can't necessarily send them a link, that kind of thing. So there are definitely barriers when it's not integrated. I will say that right now we are in the middle of a telehealth pilot, which is improving that. And we have plans to change an EMR, and we're looking at, you know, a better integration for that. But you're right, as far as older adults, they do have those challenges. They do prefer to call on the phone. They do prefer to come in. And I would say that's true for younger folks as well, that maybe don't have access. One of the challenges that we face serving those that are from potentially lower socioeconomic brackets and in rural areas, because that's where a lot of our health units are, is that we can't always get in touch with them because their phone numbers change so quickly, addresses change quickly. You know, we did a lot of things during COVID to ensure that, you know, that particular service. So for example, our Office of Public Health pharmacy, and I want to say this program kind of went above, you know, Louisiana to more of like a national level for those that were using a Depo-Provera injection, and that's, you know, to prevent pregnancy for a 3-month period. We were able to get subcutaneous and then have that mailed out directly to, you know, the recipient. And then, you know, we would get on the phone with them, you know, go through videos and other things, what we could do, or have them come the first time in person, have them administer it and teach them. So a lot of, you know, that sort of moved out to those that were comfortable, but the rest of the population very much came in person. We don't serve a whole lot of folks that are older. Possibly our immunization program is the one that would do that the most, especially where COVID is concerned. And that is also part of the reason why this year we're piloting the high dose flu, which we have not offered in the past, because that is for our older residents. And they've definitely communicated that need and that desire to have things available through us, because we're, you know, we're very specific. It's not primary care. We're very specific to those things that most impact public health. The other thing that occurred in the last, I would say, year, sort of post-COVID, if you will, although we know it's still around, we're able to better manage it, is how I view it, is that because we're able to move back into more in-person things. We did a lot of work with the National Guard doing COVID vaccinations out in the communities, and we wanted to continue that outreach into our communities. And so we've done a lot more outreach over the last year and have tried to keep track of it, try to make sure that folks were aware of our services, because we all know, I think, and if we don't, I'll tell you that our STD, HIV, and hepatitis program, we're all working hard to reduce our STD rates, our STI rates, if you will, because those are high. And we saw over the pandemic that we weren't the worst because other people got worse than us. You know, it's you know, it's mind-boggling. And I would say some things have improved even in the last year, because there was a lot of focus on it. But that was a real challenge during COVID. You know, that was one of the things that never went away. Treatment for syphilis has to be done in person, and that was always available. So there were some things that we knew needed to stay intact. But as far as interpretation, for example, during the last maybe 2 years now, we had only phone line, but we do have video interpretation through that same service. The challenge that we see with that is those smaller rural health units that don't have, and I mean, it's incredible for those of us that live, you know, in large cities, their Wi-Fi, just in general, not just because it's our health unit, but just in those parishes, they don't have that same level of technology. So it's also our older adults and the level of technology that's even available in those parishes. So I feel like there's been a huge push for on all fronts, right? That technology is there. And of course, when it fails, as we saw earlier, we don't know what to do with ourselves. But you know, there's definite advantages, and we still offer in person. So right now we're working on how can we serve folks the best? We've got video interpretation. We know how to pull in our interpreters. You know, we don't have APRNs in every single parish health unit, but if one of our nurses that are STI certified and can see and treat folks with symptoms determines they need a prescription, they can pull in an APRN via telehealth and do what we call a hybrid visit. So we're trying to meet the community where they are and trying to pull in, where we need interpretation, and let's plan on that. So that's a big pilot that we are working on currently. But a lot of it, I don't think before COVID we would have possibly considered, so if there's a silver lining to it, it's that we're trying to leverage technology where we can. And if the person is in the health unit and has seen our nurse is right there to help them with the telehealth. So that's another barrier that we're trying to break down, with them being straight telehealth, just being at home. So
I totally agree. I think COVID gave us permission to break down barriers into what we can do through extension, which you just described, where we would previously, like, we can't possibly let a provider talk to someone else and then act through that. And then it became a necessity, or it wasn't going to happen. So we've had a few silver linings we'll attribute to COVID, I suppose. David, I'm going to stick with the theme of communication. What trainings are available to ensure behavioral health professionals training Hispanic and Latinx clients are equipped to address both their cultural and linguistic needs? And with that, as I feel, there's a stigma associated with behavioral health in the Hispanic and Latinx communities pre and post COVID. What can we do to address the stigma? And I feel sometimes that that's directly associated with the language barrier, and in that our understanding of what a Hispanic Latinx culture is going through is hidden by the language barrier. So you can tell us a little bit about
Sure.
how you're addressing that.
Sure. But before, I'd like to kind of dovetail a little bit with what Deborah was saying regarding
Sure.
silver linings, because, we were, before Katrina, a lot of what we do here, we targeted Latino youth, and we would, of course, go, where are the kids? At the schools. So we would go to the schools. Well, then, obviously the schools were all closed, and we all became teachers either again or for the first time, depending on your background. And so we, the silver lining for us was that it forced us to figure out, okay, so can we get to the community, and how can we continue to do our prevention work in particular, but also to help folks access services. And we found churches and other nonprofits that we didn't even know were out there doing work, very siloed, very small, folks that come here and just volunteer and trying to help within their own communities, because they have that common culture and language, and they're not necessarily professionally trained and whatnot. So the silver lining for us was not only did we get into areas, especially the churches, but also we were able to really build capacity within the Latino community regarding, we probably got 20 some odd folks right now in the Greater New Orleans area that are doing evidence-based prevention work in Spanish. That if it wasn't for the pandemic, they would have never done it. So that's a silver lining, that we have people trained to do some prevention work. And now regarding, the question regarding the Spanish language trainings and whatnot, we have the benefit of having some funding to do mental health first aid in Spanish. And the way that our program is set up is kind of unique, that we partner with the Hispanic Chamber of Commerce. And you can imagine there's a lot of businesses that are Spanish owned or Hispanic owned and operated, and a lot of a lot of the businesses also have the staff that are majority Spanish speakers. And so we've been able to through that partnership train in Spanish a lot of managers and a lot of staff in various businesses, and to train them in mental health first aid, certifying them. And we're hoping that we can make an impact as to preventing any type of negative consequences of untreated mental health needs within our Latino community through this mechanism. So we're very excited about that. Our trainer that does this, he's I think he's the only person that does it in Spanish in the state of Louisiana. And just to kind of continue to talk about the incredible lack of Spanish speakers in multiple professions here and behavioral health professions. When he finished his certification in mental health first aid, the trainer, who's up in Connecticut or somewhere, asked him if he would be interested in doing some Spanish language trainings in their area. And I'm thinking to myself, my God, so it's not just here, it's nationally, but yeah. So we we're trying to do our best as we can. We continue to seek more funding and resources that we can address the the training needs that we have. But that's been something that we've been able to stop. We're wrapping up our first year in that. So we have several more years in that project. So hopefully we can build capacity, hire some more people, and get some more individuals trained. And then lastly, regarding training of professionals and whatnot, we are talking to folks at Holy Cross in particular to see what we can do to address the incredible shortage of Spanish speaking clinicians, mental health related. So we're in that as well. And if y'all are interested in that, we can talk about that. That might be related to a future question.
That's awesome. No, I think that everyone on the call would be like, we are hiring. The sign is out, and please join us in any way. So thank you, David, and Dr. Addison. If I can finish with the last say scheduled question, because we have some questions in the chat. But how is the Louisiana Spirit Program addressing behavioral health access disparities, and how can people contact the program?
Sure. So Louisiana Spirit has always found itself in the spot of working particularly with folks who have limited access to services, socioeconomic needs wise, but also things like transportation, which is one of the reasons we go out and do our programs in communities, so people don't have to come somewhere. We're really working very hard. It's funny, this particular version of Louisiana Spirit is the smallest version we've ever done. So normally we have many counselors, like 100 or so, or multiple hundreds, depending on the disaster. We have less than 20 for this program. So different people are taking different regions and doing their outreach that way. However, we really are working incredibly hard to meet the needs of for language issues, and I say language issues because there's many languages, as I think David or somebody might have mentioned. We have a large Vietnamese population. We have an Asian population in Homa that a lot of people never knew about until Hurricane Ida happened and the shrimping boats stopped and nobody could talk to anybody, and it was because they didn't speak what everybody thought they were going to speak. And so we, places had to get interpreters there. So we personally have, we've recently hired on a Latino woman whose actually first language is Spanish, not English. So we're hoping, she speaks both. So being bilingual, she's going to translate a lot of our documentation, information, what we hand out, and resources into Spanish, but also she's going to help us work in the field so that we can access more folks who speak Spanish as their primary language. So David and Deborah, be expecting me to be calling you. We've actually been trying to do some outreach on our own in the Latino communities locally in Baton Rouge. Now, mind you, this is a statewide program, but we're going with like where we have people who can do it, because you have to know what to say and you have to have some built-in networking already, or people are going to look at you like you're crazy, especially if you want to talk about their health, right? So yeah, sure, you don't know, but I'm going to tell you that I'm depressed today. No, we're not going to do it that way. So we have a lot of creative ways to work within the system and make our own systems, I guess you could say, in order to provide access to folks who very often have limited access to services like ours. So there's that. Then how can people contact us? I am hoping that somebody on our team at OBH has my contact information and everything I submitted in a slide, which is in my slides that will go out to everybody. But we have an entire slide that includes the Louisiana Spirit website. It has my email. It has the behavioral health keep calm line that is answered by someone all the time. And then the Louisiana Spirit phone, our team lead has a phone that people can call if they have specific questions, or say somebody from an organization wants us to come give a speech. I say speech, a workshop, a stretchment. These things can be like 30 minutes. They can be 4 hours. It's up to the needs of the entity that we're serving. So I would say that flexibility piece is our huge game here, and that we're actually trying really hard to find the languages that are most underrepresented. And then we are also working with the Governor's Office of Disability Services to get specifically some help with getting into our other entities like Louisiana School for the Blind and Deaf, because both students and caregivers need assistance there. And that's places we don't normally have the ability, just as quote unquote able-bodied folks who don't know how to interact in the way that they will receive us and get the information best. So we're working with several local groups who do that on a regular basis all day long, who I worked with during hurricane recovery mostly for the last 4 years. And we're bringing that to this program now.
Excellent. You guys covered amazing content, and I've been watching the chat, a lot of discussion and interest. We do have a few questions, and I'm going to answer a couple that were directed towards me, but I'm going to open up to our panelists to jump in as your expertise allows, sharing of knowledge. And so the first ones that came in the beginning of the hour, Bradley, there's a question about ASL and in-person ASL interpretation and online VSL provided by hospitals. It's been a huge issue in the deaf community, and wanted to hear my thoughts on that. And I agree with you, and I would say that COVID was a tremendous challenge because we had access, thanks to donors. We had a huge delivery of iPads so that we could convert all of our iPads not only to helping with the language line, but also communicating in and outside the room, so that we would minimize entry and exit, but not have someone not be able to reach a provider, but also be able to communicate with family. And we could connect them that way to maintain some sense of communication with folks who could not be in person to visit. And whenever we used our sign language interpreters, the practice is that I communicate directly with the patient, and on the side of me is the iPad where they are signing. And in this case, I'm masked. I have an N95, I have a surgical mask on. Our patient may have a tube in, they can't really speak, concentrate, they might have some sedation. And so even the best of what we had to deliver, which was virtual sign language, was not ideal in that state. And there were times where my sign language interpreter was saying you need to talk to the patient, and I was like, you're never going to hear me over the 3 machines. And so we had to adapt to what was practice, and best practices communicate directly with the patient to, I really need the message to get across. We tend not to rely on family interpreters, and I would be surprised if this is news to anyone here, because there's occasionally overinterpretation with a family member. We usually try to stick with our medical interpreters regardless of the language, so that we can be assured that what I said is communicated and it is not interpreted by a family member with family content. That being said, sometimes it is the only way we have to communicate. And so I feel the best way is to have family present with an official interpreter. And that way I know, with the interpreter's assistance, what's being said in conversation. That's my take on it. I'd be interested in the different scenarios that our panelists have been in, where you have using an interpretive service. Do you have any input from that standpoint? You guys jump in.
I'd love to jump in here. So I did want to say, and I was kind of watching the chat as well. We did a survey, and I have not been able to tackle what I intend to do with the survey with our health units because we're statewide geographically, it's really difficult to know who's hiring, who's leaving, who's new coming in. But I have definitely made it known that if our staff is saying, hey, we need more help, like none of us speak Spanish and we're very reliant on this language line and there's just not enough phones to go around. How do we follow the patient from check-in to triage to the provider? It's hard because then you're transferring, you're losing calls. So I've seen more of our health units hiring staff that are bilingual. It's slow going. I feel like we could do better in that. But, you know, state employees, we tend not to have huge turnover, but COVID changed that as well. So there's that, but there's also, and I'm watching the chat and I agree, the bilingual, bicultural is super important. Like there is, I mean, that is the best case scenario. And that's what I was able to provide. And I want to say, Dr. Williams, I was actually at the Federally Qualified Health Center that you mentioned earlier, and we had a large Hispanic population out there. That's my entire panel of patients. And I worked under your program. So what I did for them. But sometimes, you know, I ran into a situation there, for example, that we didn't have phone interpretation. It was only in person. It was a Saturday. They brought a family member. It did not go well. You know, I was like, no, you have to come back when I have somebody that can communicate with you. It wasn't Spanish, obviously, or I'd have done it. But that is problematic to use family members because you don't, or whoever it is, because you don't know if they're family members. Honestly, if you don't speak the language, you don't know who they are. But I will say, I wrote a language access plan for an FQHC here many, many years ago, and I intend to write one with the survey that, you know, we conducted a few months ago for our parish health units because we need it. Our staff, you know, the language line is not perfect. We do have some staff out there, and I know that I know that there are a couple of folks from our Region 1 health units have received some funding to have their bilingual staff, you know, become well, trained interpreters, if you will, but there are other regions of the state that definitely need that. But there's something to be said for teaching our providers some basic language, like come this way, or, you know, here's the bathroom, that kind of things, not the in-depth that I'm thinking of it provided in a medical visit. And so really trying to give them, be creative about it. And I will tell you, I have seen patients that walk around with that translator app, and it's gotten much better because I'm like, let me evaluate it. And they walked up to the checkout desk and they said something and let the person hear it. And then and then she was like, here, speak into it. And I heard it translate it. And I was like, oh, that was actually pretty good. It just told her the next time you come, bring, you know, your, bring documentation of your income to be able to see where you fall on the sliding scale. And I thought, yeah, we just need to get creative. There just aren't enough of us to go around. And you face this issue of you either fall off and you've done nothing. And if you don't address what people in desperation of trying to communicate with these folks end up doing, then you get, you know, not the best and possibly much worse than that. So I feel like you've got to give them all the tools and just try and make those as standardized as possible. But yes, I agree. The ideal would be bilingual, bicultural, everywhere, but you can't always have that. I mean, we're talking about rural Louisiana. Yep. It's not everywhere in Louisiana. I can tell you definitely the middle of the state, even though I know that's where our ICE facilities are, that our health units there don't see a huge number, but all the other parts of the state definitely do.
I'm looking forward to some, anyway, artificial intelligence. You can't turn on any type of media without hearing, and there's a huge potential in this space to be not only interpreter, but addressing that gap. And I don't think we have to worry about jobs being replaced because we have that gap there where this could potentially expand the services. And based upon how the technology works, we just need to make sure that we have the internet access and the ability to access that. But we could put a much more advanced version of Google Translate in the hands of folks who need it. So I'm hopeful. Anyone else wanted to comment? Thank you, Deborah. Very, very insightful and boots on the ground. I appreciate the insight. I want to make sure I'm not missing anyone. I think Van Lee was similar question. I've heard anecdotes of physicians who are completely lost on how to assist non-English speakers. How can we standardize training or processes for health providers and organizations to tap into remote medical interpreter services at minimum so that no patient is untreated or mistreated? It is a good question. I can speak for my small circle. We have a training program, we have a residency program, and we have a medical school where we have the junior and senior medical students training at the lake, and the language line is part of their training. And we don't have any communication in a non-English speaking, or if there's different types of impairment from a communication standpoint, we require them to document in the note, how did you actually have this conversation this morning when you talked to your patient? How did you get the history? And it's simple, but I emphasize if the language line ID number is not listed in the progress note, I'm concerned that you may have done an attempt at communication without official communication. So part of what we're trying to model is that there needs to be protection of what is vital to the exchange of information, both the patient telling us how the evening went in the hospital, and also our ability to communicate, here's your follow-up, all important medication reconciliation. It's just critical pieces that, if not done correctly, things we take advantage of. The English part is so easy, can be catastrophic for someone who just gets the dose wrong or doesn't quite understand, stop taking this, start taking that, etc. So my take on is we have to model the right way as teachers in medical education, and I would expect that to be, what the answer is across all the disciplines, where we're bringing folks in for whatever is case management, social work, or outreach. Ideally that's the expectation. That is probably a lofty goal. And panelists, any comments on that going forward? It's a tough one. And I don't know, Ava's, sorry, Iman, if we had the ability to let folks unmute and ask questions or even deliver content, I'm open. We have, I would say, looking at 6-7 minutes. May not be possible with a large number of folks online. Okay, I'll take silences, but lines are muted. So I do appreciate the participation in the chat, and also, if you haven't noticed, there's been a lot of exchange of links and resources. So if you want to grab those before we're off, I've been trying to cut and paste or capture as we went along. And just any last words, if we can go through our panelists really quickly. I do appreciate your expertise in sharing. David, let's start with you. Give a few minutes.
Just as in closing, just
sure.
I want to thank everybody for the invitation. Thank Iman for connecting us, the great connector that she is. Thank you so much. And I look forward to speaking, with anybody who's interested in helping us over here to impact the Latino communities of our state. We're in New Orleans. We're in Baton Rouge as well now. We're doing some highway safety work in Baton Rouge, and we're starting to grow our services in the Baton Rouge area. But I'm looking forward to trying to assist whenever wherever there is need. So thank you so much for the invite.
Thank you, Dr. Williams.
Yes, I really enjoyed being here. I just want to say that, we are working to try to decrease the disparities in cancer care in Louisiana. And so please, by all means, if you have someone who's having issues with access, call us. I think the number was in the chat, or you can go to louisianacancer.org and shoot us an email, and we have navigation staff that can help. We don't want to see anyone die of a preventable cancer, or a cancer that can be detected early and cured. So we'll do everything we can to get them where they need to go.
Excellent. Thank you. Deborah?
Yes, I know Iman shared our link, and I will tell you that our parish health units really consider themselves the links in their regions, if you will. Our regional leadership teams stay in touch with, hospitals, other community care providers. We know we don't do primary care, but we really try and get folks that come to us that have other needs besides the ones that we can address to whomever they need to get to in the community. In addition to that, we do have community health workers, and I believe our community health worker folks were on a previous call. And so they are also part of our network. We're just trying to make sure that, we capture everyone that is trying to fall through the cracks, as Dr. Addison has so correctly stated, to try and keep them from doing that. And I know during COVID, a lot of that happened. So we really double down on our efforts, even with the limited staff that we have out in the regions, to try and make sure that folks know about each other. Because again, those silos, even internal to our own organization, which is so large, breaking down those silos and making sure that folks communicate and know what each other are doing, as David said, that they figured out during the pandemic, I think that's key. I think it's key. You never know who's going to start a small nonprofit or trying to address in this small neighborhood that could connect with another one in another neighborhood. And they've got a huge network that can, bring everybody up to where they need to be. I think that's really important. And that is what we aim to do in our health units as well. So thank you.
Agreed. And Dr. Addison?
It's that lofty unmute button that always gets us at the last minute. I did want to say, just again, thank everybody for being here. Thank you guys for organizing this. But also, I want to say, this is crazy because I know what Dr. Donna Williams was saying about we don't want anybody to die from a cancer that's preventable. Well, a lot of times we don't talk about the elephant in the room. So our program is also because we don't want anyone to die from suicide. And I really do believe that programs like ours can help meet that gap between people who are like, so functioning, to people who are really not so okay, but are going to work anyways and being miserable and depressed and anxious at work and not functioning elsewhere in their lives because they're having to put it into work. And we don't want anyone to ever get to that point of no hope and no return. And so hopefully we can help people with what we might call it prevention. I don't know. I just think it's part of our daily life now, is if we can stop the bad cancers, if we can stop the illnesses before they get to a point of uncurable, and suicide is the uncurable part of mental health. You cannot come back from that. So I just want to be able to give everybody the access to having that opportunity, because every human is important in my mind. I value life. And I think we all do. Everyone who's here does, obviously. And I wish this was a series that we met every week now for coffee. But I know I'm probably such a goofball, but it's really true. So expect me to be following up with all of you. Thank you so much. Appreciate it.
Thank you. And I think pointing out that this was a tremendous networking opportunity. Please take advantage. Avis, if I can turn it back to you, and we got some housekeeping, we'll close up.
Absolutely. And I think that Dr. Jagno, thank you so much for your opening comments. I definitely think it set the tone for a lot of the discussion that happened this afternoon. And I think one of the overriding themes for that was language barriers, cultural barriers that still are, make our work a little bit more difficult in trying to address social determinants of health. But I know convening this group is going to help to leverage all the things that you guys have said on the discussion today. I do want to remind you all to please take the survey that is prepared, that you will receive after our call today. So thank you all so much for joining us today, and thank you for the individuals who joined us. There were over 130 individuals who joined us today. So we want to make sure that we make these connections and provide the information to you. We will provide the video to you and edited video to you all. So thank you to the panelists, and especially thank you to the Bureau of Community Partnerships and Health Equity, our Bureau of Media and Communications, for executing this conversation. And with that, this will conclude our webinar. So thank you all today.
Thank you.